Okay, and welcome to this episode of BurnCast, where we're going to be talking about occupational therapy, physical therapy, and the combined makes burn therapy. And that's not talking to burns about their feelings. It's something very different. And we have a special guest today. This is Stephanie. She is one of our occupational therapists. And of course, we have Anne and Liz. So Stephanie, could you go ahead and start off by introducing yourself and just kind of telling us what you do, and we'll go from there.
Sounds good. I'm Stephanie. As Cindy said, I'm an occupational therapist here, working very closely with the burn team and the physical therapist as well to help put the whole picture together with our children here. And we are really everywhere in the hospital. Sometimes we'll start out in the emergency department, surgical floor, ICUs, and you'll see us all over.
So when I think occupational therapy and physical therapy, I always used to think occupational was with your hands and physical therapy was with your feet. Is that a good way to think about it, or a way to know whether, how does a bedside nurse know, I think we need OT or I think we need PT? What would make that decision? What's the difference between them?
That's a really great question. There is a lot of overlap between the therapies. It's true that occupational therapists work a lot more on fine motor skills, and that's all the little skills with your hands, whether it's putting up a zipper or doing buttons and brushing your teeth. OTs work a lot on the everyday activities just to help people be more independent and participate in their daily routine. And physical therapists, they might describe what they do as more gross motor skills, like walking and jumping and endurance and strengthening. In burn therapy, so I'll go back. So that's why sometimes it looks like the body's cut in half. So we have hands for the OTs and legs for the PTs, but really we're looking at the whole body, and our goals are all about function. In burn therapy, we do it all, but yes, OTs might work a little bit more on splinting for the hands and positioning of the upper body, and PTs might focus a little bit more on the specific feet position and braces for the legs, but we're constantly working together.
So Anne or Liz, is it automatic that OT and PT get involved with our burn patients, or is it only if they're in the pediatric ICU, or is it only outpatient or surgical care? Can you go through the process of getting Stephanie involved and why it's important?
Yeah, I would say that most of our burn patients that are in the hospital have some form of burn therapy involvement, depending on the location of the burn. And that probably has a lot to do with the fact that we have criteria for when somebody is admitted. And usually that's a larger burn or a functionally impacting burn or a deeper burn. So a lot of times we do have therapy involved, especially if it's over a major joint, or, as Stephanie was talking about, hands trying to get back into kind of function. Our number one goal is always function when it comes to a burn injury. And then we obviously want healing of the wound and skin and whatnot, but we want your body to be continuing to function as you're creating scars or healing or whatever that might be. When it comes to the outpatient in burn clinic, we consult or ask physical and occupational therapy or our burn therapist to come see our patients if there is a functional impact for that patient. So not every single burn patient sees them, but anybody who kind of needs help with getting back to their normal function.
And that's definitely in the acute burn process in those first couple of weeks following the injury, while we're still, doing dressing changes and, frequent wound assessments. But then it's very important to recognize that there are patients at higher risk for scarring or who do develop scarring. So PT and OT play an integral role in scar assessment, scar management. And Steph, do you want to kind of quickly talk about that? What we do if we recognize that a patient has a scar that may impact them either cosmetically or functionally.
Yeah, sometimes I think it used to look like if a burn crosses a joint, then we would be involved in clinic. But now we're finding that some of the deeper burns, even if it doesn't cross a joint, we find that there's restrictions with the skin tightness. When the scar develops, they might not actually be able to extend their elbow, even if the burn doesn't ever cross the elbow. And so that's also when I just wanted to add that also is when we would be consulted for burn clinic. And for scar management, we've become much more involved in the last couple of years in management, where we work on measuring for compression garments, and that's to help with the scars staying as flat as possible and more of an organized scar tissue setup. And we work on a lot of teaching about scar management, scar massage, moisturizing, and along with the team, we're always encouraging. So many of us talk about very similar things, and it's all at the angle of function and also how to help minimize the impact of a scar. And so we'll do compression garments. And if a child doesn't need compression garments, but there is some concern about how it's looking, we'll also look into other options like silicone gel sheets to help with the softening of the scar and continue with movement and range of motion throughout as the scar is maturing.
So are your, can you explain what a compression garment is? And what our inpatient nurses ever see oh, you have one. Oh, yay.
No, I wish I had one. I have one in the other room.
Oh.
I'm sorry.
Can you explain what it is and discuss whether our inpatient nurse would ever see a compression garment?
Mm-hmm. We start talking about providing compression to wounds pretty early on in the process. So even when there's the wound dressings, the fact that they're wrapped up in the Curlex and sometimes the ACE wrap, that's applying early compression. In our inpatient burns, if they're here long enough, as the burns start healing, we get them into interim compression. So that might be a tubular bandage that has elastic properties to help give that constriction. So those are just, the tubular garments. Usually they might be home by the time, or in rehab by the time they get customized garments, which we take a measurement at each, basically get every inch of their arm. It's very customized to provide enough pressure. And that happens later when the wounds are closed and healed. So you will see the interim compression, but not always the customized, because it does take about 3 weeks to receive it, and we usually start measuring once the wounds are closed.
And so when you say compression garment, it kind of sounds like Spanx for burns. Is that are they hard for kids to put on?
That's a great question too, because they, I would say the interim compression, which gives a little bit of support, those are maybe more like the Spanx or the compression off the shelf compression socks, similar for edema management. That's what it looks like. The customized garments are a lot tighter, and with that, some of the kids really like how it feels because it helps with the itching and it helps with it just often will just feel better for them. And then we have some kids that just don't tolerate it, so we try to go back to the interim compression to work our way up to the garment wearing, because it should be on for 23 hours a day.
Oh, that's a long time.
Mm-hmm.
Mm-hmm.
What hour do they not wear it?
Before bath time.
So they don't wear it when they're in the bathtub.
No,
Something they are not supposed to get
point.
wet. Okay.
Mm-hmm. Yeah.
And families will ask that too, if kids can go swimming with them on. And Steph, what do you tell them about, sun protection and swimming and things like that?
Yeah, I think it is such a balance, because we do want these kids to have fun too and not feel like they're always having to be in an intervention or always wearing something. And so having breaks is okay. And so for swimming, yes, we definitely say you can take them off, have fun at the pool, have fun at the beach, but of course, sun protection is huge. So we usually tell them wearing those like SPF long, cool looking, I don't know, what do you call those? The full water
sun shirts.
The long sleeve shirts.
Sun shirts.
Yeah. The surf, and the surfers make it look really cool. So I think they look good. Now I think it's much more common to have the sun shorts and even sun leggings. So we do recommend definite coverage when they're out and about. And Cindy, one other thing about the Spanx, before they get compression, if they have a burn on their leg or if they've had a donor site that needs some compression, we often will recommend them getting off the shelf bike shorts or spandex just to start that compression. It doesn't give much, but it gives that feeling of having something against their skin.
Oh, so they kind of get used to it before they have to get used to it.
Mm-hmm.
Okay.
Yes.
I'm trying to think of like, what's the best way to explain the importance of burn therapy once it's ordered? So could we maybe start, and we'll say like in the PICU with like a 2-year-old that like, and you can pick any example that you want, because I'm sure like you've been here for a minute and a half. So maybe, Anne, could you explain like a case where you, without like major details, where you consulted for burn therapy, and like then Stephanie, maybe go through the goals from the PICU, then they go to surgical care, and then they go home and afterwards. But I think that like starting from like the most critical time in the recovery and like the different goals and importance for each one. And I'll make sure we stay on track. So first ordering, why we would order again, and then like what are the goals in the PICU?
I think we could start with two major examples that one would be a neck burn, like to kind of this general area to the neck and chin, which can be really important for range of motion. And Stephanie can probably talk a little bit more about that. But the other thing is shoulders or kind of over the arm burns a lot. And the reason that I'm choosing these two, and I know I chose two, I'm sorry, you asked for one example, but it's because I think well, you could have both, right? If they're pretty close to each other. They're pretty close to each other. It goes like,
it's like,
this.
Especially if you're in the PICU. Yeah.
Yeah. Or a big flame burn that is very deep to these areas. And the reason that I chose those two is because I think they're extremely important in the ICU to get position and range of motion started early. And it's not just doing some stretches every now and then during the day. It can be about having the arm elevated or kind of it, and that's when our physical and occupational therapists, they have such expertise in, we start with our preventative, and then we work through more of like treatment. And then some patients are even discharged from burn clinic and continue to work with our therapists. So we can go into more details, but Steph, what do you think is most important for ICU team to know? I think that we should get them involved on day one with a large, deep burn to the neck and shoulder.
Yes, I was going to say that earlier the better. As soon as, even if there's still questions of stability, we're not doing anything crazy. So I don't want you to feel like we come in there and we're like, we're going to get them up to walk. We really want to get there early just to assess the positions of the burns and where they're crossing the joints. So in this scenario with a neck burn and shoulder burn, which we do see often, the biggest thing is when they're in their beds, often you might see them kind of slouching down with their chin tucked in. And that's the last place we want them, because everything as it heals, it starts getting tightened up here. So you'll see big signs to say no pillows behind the neck, no pillows behind the head. Okay to have it lower on the back, but we really want to encourage the open neck area. And even when our kids are intubated, as long as the team, the RTs and the medical team are okay with it, we want them as extended as possible. We need to be mindful of the position of the vent, because that tubing pulls them sometimes to one side. And if they have a burn on that side, the skin and the muscles underneath can shorten too. And it happens relatively quickly. So we often would say, if we even can change the vent to the other side every other day, I know that's a lot. So there's ways that we can work very closely with the RTs and the team and the nurses to make sure that we're getting full range of motion at the neck, and making sure when they're in their position, if they're sedated, that they really have a nice open neck position. The shoulder gets a little tricky because
there's shoulder and axilla too, right? Like kind of the whole area.
Right. Yeah. Mm-hmm. Exactly. So if you have the neck extended, you can't really have the arms up this way, because then you lose some of that shoulder. So sometimes what we'll do is we'll work on the neck extension with the shoulder elevated to maybe about like 80 degrees to help with that stretching underneath the axilla. And then if their head is more neutral, then we could raise their arms up even higher. And we do our best to put photos and pictures and instructions about positioning, and also being mindful that it really can change very quickly. So for example, I was going to change the scenario. We're going to talk about someone who has a neck, shoulder, axilla, and how about elbow?
Okay. Or adding on.
Yeah.
That's okay.
Because just a lot of times, like we will, nursing staff might see a change where it used to be that we always wanted their elbow extended at all times. And then we find that they actually might have a contracture in coming into flexion. So we might actually say, okay, now you want them just resting like this. I'm sorry if my video quality is very poor, I think. Is it blurry on your end?
Yeah, it is, but we can still see your arm moving.
Sorry
so.
about that. It's a little yeah. So yeah, so you might find that we'll be saying first everything extended and like, okay, today we need it flex, and we might be going back and forth between that. Or after an OR visit, we might have a change in the position and what's appropriate and what's not. So getting us in there very early for us to be able to assess that position is important. And one more thing I was going to mention about edema, which is a huge thing after a burn. We talk about elevating the extremities to help with the edema management as well.
I'm so glad that you started off this explanation by saying when burn therapy comes in the room, don't think we're going to be like, okay, it's time to walk. Because I feel like that may be every PICU nurse's nightmare of like, oh my gosh, what are we going to do? Like there's burns everywhere. Like I'm worried about this tube being secure. But I think when like explaining that the focus is range of motion and not letting things get stuck in a certain space. And I love the way you explained about like having that neck out because you don't want it to, I feel like, you know, all of us have been here for a minute and a half and we've seen the kids like a year later that are kind of stuck like this. And then that takes like surgeries and a lot more afterwards because they're kind of stuck like that. And, you know, they can't do all of these things. So that was extremely helpful.
Yeah. In the beginning, it's about positioning, right? It's not always about very active range of motion. It's about positioning so that you're starting in the right kind of position. It's not exactly what I was trying to say, but
no, but also that we're offloading pressure because you know that these can get these you know skin breakdown, and you know we see a lot of these kids even with maybe not skin breakdown but just some alopecia, just some hair loss because of you know being in the same position. So your team can definitely help the bedside nurses with some offloading.
Yeah, and we want to And we want to be as helpful as possible because yes, if they're on their side or in supine and then they go onto their side, we might have their arms out to the side. And now when we're on their side, we want them hands together to stretch out the back of the shoulder. So we can show different ways of positioning in all the different areas because constantly they're being, nursing staff is great about repositioning, and we could just help with once they're positioned in a different, oh, we're saying position a lot. Once they're in a different
that's what I felt too.
Using pillows and blanket rolls and lots of different ways. Sometimes we'll make the splints, the hard splints, to give a really good stretch for the neck so they maintain that position, or for the axilla. And sometimes with those also earlier is better.
So what would be, well, actually first, how do you communicate what position is best for the patient at that time? Because what I'm hearing is it can change after an OR, it can change day to day. So how does the nurse know? So say like, you know, you come during the daytime. We don't do burn therapy overnight with the therapist. So how does the night nurse know what happened during the day?
Yeah, as being part of the burn team, we're always in a lot of coordination. And so often if there's a change, we'll have the nurse practitioners put in an order just to mention about, shoulder, 90-degree abduction, legs or feet elevated on pillows. So we really do communicate that, and the orders get changed, activity orders get changed. Or sometimes it might be, we have the paper at bedside, and I might just cross out and say as of, and have a different date, and maybe just modify that until we have the new plan. And then sometimes for some of the kids that are here a long time, we have to go through a few of those to keep changing it. So we just do a lot of communication. I think that's what we found was best with the activity orders being changed in the chart.
Okay. Anything else about the PICU, Liz or Anne, that you think it would be helpful to ask? Or
Is there anything that, Steph, that you would want the PICU bedside nurse to communicate with you before a session, or kind of what does that kind of look like? How often can they expect you or a physical therapist to come? Kind of just what's the day-to-day?
Yeah. Usually when we call up in the morning to get a sense of a good time for us to come in, it's often we'll ask about pain. And if they're due for a scheduled pain medicine, we'll definitely work to coordinate with the timing of that. If pain hasn't been a big issue, we still want to see what time is good for the nursing staff, because if it's one thing if we're doing positioning, but often in the ICU, they are ready to get out of bed for the first time. Sometimes not even that much later than admission. So we will work with the nurses to get them out of bed and show how to do it, because like you said, we're not always there. And we really do want them to be able to start using a commode when appropriate. We want them to get up and move. So with nursing staff showing how we do the handling and where we can put our hands, as well as teaching even families as early as the ICU, we'll start doing that. So just as I keep saying, the biggest thing is the coordination and communication with everyone involved.
And would you say that we generally
Would
you say that we generally do want early mobilization as much as possible within the limits of any sort of positioning restrictions or weight bearing restrictions due to surgical interventions or grafts? Like otherwise we do generally want to get people up and moving as early as we can?
Yes. There's a whole push in not just burn therapy, but in general, ICU work is about early mobilization, particularly with the burn patients, because they have had, they need to start moving as much as possible for many reasons. We can go into that another time, but with that, we would, as soon as they're stable enough, we would love to get them up and out of bed. And that's back to Liz's question about the what information we like to know from the nurses is definitely about their stability, and if their blood pressures are stable, we can sit up in bed, can we get out of bed, can we use the commode, just all of that communication. But yes, we want them moving as much as possible. And also when we're not there, if they're just doing positional changes, having the nurses encourage them to help actively with the movements, keep their strength.
Okay, so let's move to surgical care. So in surgical care, there's no breathing tubes, which makes life so much easier for movement. I'm sure that you're like, okay, now we can really do some movement now. I feel like in the PICU, it's there's always a lot of things going on, and there's a lot of hardware going on around that can make movement more restrictive. So if burn therapy is involved in the ICU, we know that burn therapy is going to be involved on surgical care. Like, is that like that's an always?
Oh yeah, I would say so. Mm-hmm. Mm-hmm.
So then what happens on surgical care?
So once they get to surgical care, they already know us pretty well by then, because they've seen us a lot. And like you said, there's less lines and tubes. And so our goal is increase the mobility, get them out of bed, normalize their routine, getting up to the bathroom to brush their teeth, wash up, use the toilet, and definitely the push when they're ready for it, working on the showers too, but that's later on. If it's a younger child, we'll bring a play mat into the room, we'll get them down and playing. And sometimes it's a little slower moving than that. Maybe they're not even ready to get out of bed yet still, but we would work on a lot of passive range of motion, active range of motion, still working on positioning. And sometimes it might take about an hour and a half to 2 hours to get someone out of bed, but we'll do that.
Tell me about the gym on the surgical care floor, because I've been there, and I think it's so cool, and not a lot of people haven't even seen it. So could you tell us a little bit about that?
Yes, it was a donation from the Liz?
DC Firefighter Burn.
DC Firefighter Burn.
I want to make
Foundation,
sure, yes, Burn Foundation. Okay, I want to make sure.
And the Redskins,
so donation,
right? The Redskins they helped us with
oh,
that.
Yeah.
Yeah, because that guy came.
I think so.
He was a Redskin.
Yeah.
I forgot. He was tall. He was a football player. the worst.
Oh yeah, Kerrigan, I think.
Yeah, that guy.
Yeah. Yeah, so it was made because a lot of the kids were kind of stuck in their rooms. They weren't quite comfortable being in the hallway. We didn't really have any place to go to really progress their therapy. So this wonderful donation came by, and we have a gym that's set up with a high and low mat and an exercise bike and just more space to move, a physio ball. And so it just helps. We can take them out of their room and just, again, that normalcy, just getting out and about, and more of a change in environment is huge for these kids. Mm-hmm.
Anne or Liz, do you have any things that you think that would be helpful for I know the surgical care nurses understand burn therapy, and I'm sure that when they see you coming, they're like, all right, I've got help. I've got somebody who's going to help me like get this kiddo back home. And I'm sure they are like welcoming you with open arms. But any other like thoughts about like goals or anything during this time? Because
I think it's important to note that the therapists are extremely helpful and extremely knowledgeable, but they're also there to educate the rest of us. So they're there to help the nurses, help the patients, and help the families help the patients, because Steph can't come by every time somebody has to pee to get them out of bed, right? So she is here, or our team is here to kind of help the first few times, or sometimes they really need to work on their therapy and not the burn dressing change, because a lot of times we try and coordinate those at the same time with pre-medications, but just making sure that we're using their time and not abusing their time, and also taking tips from them in terms of how we can also best help the patients in terms of their therapy goals and their mobilization and their range of motion.
Definitely. And Steph, can you talk a little bit more about how you and PT work together? That would be interesting, because a lot of times I'm sure folks are like, why is there a PT and an OT order?
Yeah. And just quickly, just to follow up with what Anne was saying, it is really nice to, so many times you need everyone, the nurse, the PT, the OT, getting out of bed. And sometimes it really is the child or the family might not think that they're ready to get out of bed without us there, because they start relying on that. And so it's true that we really do hope to pass along just the different techniques of how we've been getting out of bed. Some kids want to roll and sit up. Some kids want to use the chair mode in the bed to sit up. So there's definitely, we want to figure it out as a team together, what's the best way, and so that there could be carryover when we're not there. And then, as I said before, the theme is always things do change. So eventually we don't want them relying on the position of the bed to help them up. We want them to get out from a flat bed. So then we say, okay, new plan, we're going to get out as if it's a normal bed without any head position changes. So I just wanted to, encourage that. That is what we hope to be able to help with as well. And then, Liz, can you repeat that?
Oh, sure. More of a question of how do you and how does OT and PT
I remember.
Both are consulted, and what's the importance of having, both of those orders in?
Yes. So sometimes you might find that we will get both of us consulted, and we might only just one of us do an evaluation. And that's where you might see are we cutting the body in half? Because if it's more of a upper body burn, we'll just say, okay, OT, we'll just take this. Or if it's lower body, maybe PT will just take it. For those kids, they really, maybe they're moving around fine, they're doing their ADLs fine, but they just need to work on walking and the physical mobility of endurance. And then PT might just see them. And someone who maybe it was a hand burn, but they were admitted because it was very deep, OT will probably just see them for working on mobility and range. When we have us both together, often it's for the bigger burns, and often we will co-treat at the same time for the first few times out of bed. And sometimes if a child needs a lot of support to even stand up and walk, we'll do it together until we realize that, okay, they're comfortable with one person and a family member, or one person and the nurse, and then we'll separate the sessions again. And again, with the bigger burns, we also try to do at least one in the morning therapy and one in the afternoon, sometimes twice in the morning, depending on the child. And with that, if there's we want to work on range of motion and stretches, but we also want to work on out of bed mobility. One of us might take, okay, we'll do the stretches in the morning because they have a busy morning with the dressing change and they need to be in bed anyway. And then the afternoon we'll focus on out of bed mobility. So we'll coordinate with each other to see what the needs are at the moment.
I think that's it's so interesting. And you know, before I started working in a hospital, I really did not understand I didn't understand what burn therapy was or what it did for the patients. But I feel like without burn therapy, none of our kids would be kids again. And that's what you bring to them. So thank you for that. And for our audience, could you, not that I want any nurse to like go to OT or PT school, but could you tell everybody kind of like what the training is like and like what that degree is? Because I think that a lot of people don't know that either. And I find it really interesting.
Yeah, sure. Thanks for saying what you're saying. We love being part of the burn team because we also think it's very important. But I do want to note that I know that the whole team, everyone's focus is on independence, and whether you have to doing the dressing changes is leading them up to being able to do that. So even as a nurse, if you feel like, oh, it's just causing pain and what are we really doing here? It's all so that they can be independent and get back to playing and doing what they like to do. And then one other thing I wanted to mention about surgical unit, sorry, Cindy, and then I'll answer that question.
Totally great.
Is a big part of what does happen is some of the kids get very, very down and or angry or upset, and we see them going from really energetic and like they're really motivated to get out of bed, maybe even in ICU, they're ready to go and move, and then over time they start withdrawing more and not wanting to be participating. And so we of course get our burn psychologists and child life involved, but it's a huge part of the inpatient stay is we do see those highs and lows, and we just want to keep encouraging them and keep reminding them about why we're doing what we're doing. So I just wanted to mention that.
No, I think that's a really important part to bring up, that you know, burns aren't easy. You know, and they take a long time to heal. It's not like a broken bone where you put it in a cast and then like a month later you take off the cast and yay, everything's good. You're having to look at an injury every day. It can affect how you brush your teeth. It can affect how you play a video game. It can affect how you get out of bed. And I think that's why, I mean, that's the number one reason why we do these burn casts, is to figure out like different and better ways for us to all like work together, because we all have the same common goal to get kids to, you know, go back to being kids and to go home and to be okay.
Definitely. When we face those barriers, the psychological barriers, it's huge because sometimes we're not even going to be able to get them out of bed or even do a stretch. And we might just sit there and just talk about their goals and what they like to do and slowly get back to getting up and moving. And that's, the whole team knowing that it can be very emotional, of course, for those stages, and to help them through that.
So Stephanie, why do you like working with our burn patients?
Oh, I love it. I think part of it, well, when I first started, so I'll back up about schooling, and then that kind of brings me to where we are now. I didn't forget the question. But it's for OT, it's now master's level is entry level. So it's a graduate degree. Some schools have 5-year programs and others you go for the master's, and the field is going towards the doctorate. So I did a clinical doctorate at the time of my schooling, but it wasn't mandatory, and it's not yet. Whereas physical therapy, the entry level is the doctor of physical therapy. So they all have clinical doctorates. And so I think the OT field is moving in that direction, but there's still a little pushback because some people want to keep a master's level for more access.
Same thing with nurse practitioners. It's very similar because it's always been in master's level, but now they're pushing for a doctorate level for nurse practitioners. So that's interesting. It's very similar. Yeah. And
I'm not so involved in the academic side, so now I'm not actually sure where they're at. But I don't think it's mandatory yet, but it is. I think it might be soon. And so that brings me to coming to children's. Actually, to be honest, burn therapy, when I first started, I would watch the other therapists that I was training, and I said, nope, not for me. No. I don't want to do this. How can I do it? Just causing so much pain. And that's all I could see about it at the time. Like when we're doing the stretches, it's very difficult to see the kids crying, the parents crying, and they don't quite understand why we're doing what we're doing. But why I love it is over time, I learned more and more about really the mechanics of a burn and scar and what can happen if we don't do it. And so now my new thing is a lot of, I mean, not the new thing, but I'm much more, I spend a lot more time teaching the parents and the children about why we're doing what we're doing. And the hope is that they never see what we're trying to prevent. So it's kind of hard to understand that without knowing what it could, how bad it could be without moving. So I just try to remind them about why we're doing it. And that helps me too. So I know every time I'm doing a stretch, and we try to do it in a way that they can tolerate. And sometimes they can't tolerate as much, but knowing that this is going to help them to be able to reach for the ball, and this is going to help them to be able to brush their teeth. And I say that out loud. So I remind them about all those things. And so putting it all together, I love the hands-on, more like the medical side of it. As an OT, it's kind of fun because I'm in a hospital setting. So I love the medical side of burns. And then I love the functional work and why we're getting them up and moving. And I also really love the psychosocial part about reintegration, what we're going to do after we leave the hospital, how do we get back involved, the social support. So it kind of combines, for me personally, all of my interests together.
That's so cool. I'm so glad that you are part of our team. So we have gone from the PICU to surgical care. Are there certain things that a patient has to be able to do on their own before they go home?
Well, some patients don't go home.
I mean,
Oh yeah, good point.
That's a
from the
good point.
hospital,
Okay.
right?
Yeah, so it's, again, a big team decision. We get rehab, physical medicine and rehab involved with some of our discharge planning. And it's really often, it's a decision about whether or not they're going to excel better and maximize their potential in rehab, or if they're going to do better in their home environment. For some of the kids struggling psychosocially, sometimes we will have them go home because the families really understand what needs to be done, as long as they're safe with mobility and safe with transfers. We can work on the ADLs later. But for the kids that we think that we could really maximize their potential and return to their day-to-day activities and more independence, rehab's a great option for them. So we do have to, throughout their whole stay, we are constantly deciding how they're doing. And sometimes they might be on in the direction of rehab and they just do great. And then we say, oh, you're ready to go home with outpatient services.
I was going to say from our burn rounds to sessions, it sounds like it is a very fluid conversation where things can certainly change right prior to discharge. What's the ideal time to get physical medicine involved, like a formal physical medicine rehab consult?
Mm-hmm. I think earlier is better because they could start building rapport with the family. I think if it's the larger burns that are having trouble with mobility, or someone who's having a lot of skin grafts done, and they're going to have donor sites. And I mean, it's still pretty temporary with the donor, with sometimes limited mobility is because of pain. And if the pain's managed and things are healing, those are the kids that are like, oh, we thought you might need rehab and you don't. But I don't think it ever hurts to get physical medicine involved, because they could start talking to the families about the process and the possibility of rehab, and for them to understand it. So it's not always like, we know we're going home right after this. If they need rehab, it's nice to start those conversations earlier. Mm-hmm.
Okay, so I think with wrapping up, what is I'm going to ask you all three this. I always have like wrap up questions, Stephanie. So I'll let you go last, and I'm going to have Liz go first, and then Ann, and then you. So Liz, what are like the two main takeaway points for our nursing staff watching this or listening to this that you want them to remember about burn therapy?
So I think that it's challenging, right? I think that Stephanie makes a really good point in terms of having that coordination with the therapist about proper pain management beforehand. So I think that's, really important component. But I also think that we need to address the anxiety component of it too. So maybe that should be involved in the discussion, whether it's a medication, whether it's having child life, what kind of support or distraction. But again, just to remember that this is tough. This is part of that road to recovery. It is not easy. It's critical, but then there are some things we can do to make it more comfortable for the patient and the family.
My turn.
Yeah. So like we want to set kids up for success and
Yeah.
think and just remember that it's not just physical pain, it's also a lot of anxiety as well.
I think anxiety is a huge component.
Yeah.
Then that was a really good point, Liz. I think my take homes would be to get therapy involved from the beginning. Our burn therapists and I mean physical and occupational therapy, and that there's a lot that we can do bedside just in terms of small things that make a big difference, and that our number one goal is function, that we want patients to go home with as much function as they can and not a lot of change from their baseline if we can manage that. So that I think is one of our biggest goals, and that's something that takes a lot of repetition, I think. And so that can be challenging to know that you don't see them. It's not like you're taking off a bandage and it looks a little bit better. It's a very slow, we're constantly working on it, and you can see progress over time.
It's a slow burn. LOL.
Thanks, Cindy.
Sorry. I can't help it. I haven't had lunch yet. And then Stephanie. First, thank you so much for joining us. And
it was so fun. Thank you.
I'm interested to see what your take-home points are.
I think just thinking about the continuum of care, starting in the ICU, going to the step-down unit, the floor, and then going to outpatient clinics and follow up sometimes years later for maybe a surgery later, maybe getting in touch with them for getting them involved in burn camps out of the year for the social side of things. And just the communication and coordination with the whole team is crucial. And I love working with nursing staff, and I think that it's so nice to see the different roles that we all play and see how much we all have the common goal, and I think it's the communication is huge for carryover and being open for changes, and letting us know if things aren't working, or the ways that if a position's just the child's not tolerating it, how we can work together to get something that does work. So yes, there we go.